This podcast covers the subject of spirituality and death very briefly. There is a course at the college called The Spiritual Dimensions of Death and Dying that covers this material in a lot more detail if you're interested in going into the subject some more. Generally speaking, death and dying is a subject that's handled mostly by specialists in palliative care. But since palliative care is a relatively small percentage of the healthcare profession, and since everybody in the healthcare profession has to deal with the subject of death and dying, it's appropriate for this to be included in a general curriculum on healthcare. The reality, of course, is that all patients are terminal, and for that matter, so are all healthcare professionals. We are all human, we are all mortal, and we will all die. That's a sure thing. The mortality rate for the human race is, and always has been, 100%, beats the mortality rate on every disease that you will ever study. So in that sense, all healthcare is palliative care, because all the patients that we care for are in the process of dying. Not a very cheery perspective, but it's an accurate one. So the line between curative care and palliative care is really not as broad as might be suspected at first glance. Curative care, of course, is always trying to restore function so that, for example, a person who has a broken leg is going to have the use of that leg restored. A person who's had cancer is going to have that cancer killed or cut out so that they can continue with their life the way they were before they got diagnosed with cancer. Palliative care is more about slowing down the loss of function so that it is inevitable that this person is going to die and they are in the last stages of life, but we'd like to see them continue to be as functional as possible for as long as possible so that they are not losing function faster than they must, and they're continuing to be able to do some of the things that they would like to do as long as they possibly can. There is, of course, the aspect of comfort care in palliative care, that patients are given pain control measures and other kinds of comfort care, whatever it takes to keep them as comfortable as they can possibly be while they go through the dying process. When death is imminent, then the perspective changes just a little bit, and one of the things that happens when death is imminent is that the healthcare professionals all realize there's nothing more that can be done. All we can do basically is keep the patient comfortable. He's not a candidate for any more treatment. And at that point, it tends to become a different kind of relationship between the dying patient and his or her healthcare professionals. For one thing, it's fairly well known that healthcare professionals tend to avoid people who are dying. They tend to make themselves scarce. They may not make their visits as often. They may not stay as long. There are a number of reasons for this, one of which, of course, is self-protection. We see in the dying person our own dying selves, and so we are not very comfortable with that, and we try to avoid it. But another part of it has to do with the way healthcare professionals relate to the whole subject of dying and medicine's attitude toward death. Medicine, at least in modern times, has seen death as the great enemy, and not, as in earlier times, as the ultimate friend. When death is the great enemy, then you do whatever you can to try to hold death off, to vanquish it if possible, and if it isn't possible, then to push it away as long as you possibly can. When you have that kind of an attitude towards death and you don't see death as a part of life or an inevitable result, and you don't realize clearly that all your patients are going to die and that the best thing you can do is help them to die well, then the attitude is that death brings failure, and nobody likes to feel like a failure. So healthcare professionals tend to avoid the dying patient because he or she makes him or her feel like a failure. Medicine's attitude toward the dying tends then to neglect the dying and deal as much as possible with the living. And of course, there are lots of good reasons that we can tell ourselves about that. The living need me and the dying person really doesn't. And if I can help the living to live longer, that's more important than helping the dying to die. It really isn't true. all of us have to die, and the very best thing we can do is to help other people to die well and for ourselves to die well. Society's attitude toward death and dying is also not terribly healthy. People talk about if I die when they really should talk about when I die. And generally speaking, in our society, when people are in the act of dying, we rush them to the emergency room, and then from there they go to the ICU, and typically they will die in the hospital. Although that's beginning to change more and more now with the advent of better palliative care, patients are dying in hospice or at home. But in the 50s, 60s, 70s, death was very much something that was banished to the hospital, and so there are many people who never really saw anybody go through the act of dying, and many people who have never seen, even in their adult life, a dead person as he really is. We take them to the funeral home, and who'd want to live there? And we have the funeral director, we don't even like the word mortician, make the person up and dress them and put glasses on them and put them in their best clothes and put them in a nice casket and surround them with flowers so we don't have to smell the smell of death, and put them under nice pink lights so that they look like they're alive, and then all their friends and relatives walk by and say, "My, how natural he looks." Well, of course, death is natural, but that's not what they're talking about. They're talking about how much this person looks like he's just sleeping instead of being dead. And society's attitude is reflected in all of that, an attitude of rejection of death, a fear of death, an unwillingness to embrace death as a part of life. The dying have a number of needs, and these needs ought not to be denied. They are basic human rights. The dying person has a right to pain control. In our society, it is not necessary for people to die in pain. It is not necessary for people to suffer from unrelieved pain. We have the tools so that that just plain isn't necessary anymore. People have the right to have company on the journey towards the end. They don't need to die alone. In fact, as a healthcare professional, you ought to be able to promise people there are two things that you will be sure of that you can do for them, and that is that you will do your very best to make sure that they don't die in pain, and secondly, that you'll do your very best to see that they don't die alone. A person who's dying has a right to dignity. Generally, this means a right to autonomy and to a measure of control over their own lives, when they want to take their pain pills or if they want to, whether they want further treatment, whether they don't, when they want to eat, if they don't want to eat, if they don't want any further hydration, if they don't want any artificial measures to prolong their lives, they don't want treatment for their whatever it might be, they don't want to be on a ventilator. Those are rights that they have, autonomy over their own bodies. And of course, another thing that dying persons need is meaning. They want to be assured that their life counts for something, that the world's going to notice when they go, that there was a significance to their lives, a meaning and a value and purpose. And by now, of course, you recognize that these are spiritual words. This is the very language of spirituality, that I lived my life, it had meaning, it had value, it had purpose. And now at the end of my life, I can look back over it and I can know that it was worth living and that it counted for something.